Good evening, everybody. We are going to talk something about an aortic aneurysm stenting, and it's a very vast topic. But we're just going to start from the very basics. Then, starting from arteries, which are very important when you do in an abdominal aortic aneurysm stenting. So I'm not going to cover the thoracic part because it's a very vast topic. So I can't cover in half an hour everything. So we know the layers of the arterial wall is the intima inside, media in the middle, which is a muscular layer, and the adventitia, which is there outside. Now there are various branches of aorta, which are very, very important when we do the aortic aneurysm scanning and planning, and you must know exactly where those arteries are. Let's start with the first branch, which comes out from an abdominal aorta, what we call celiac artery. It comes out at the level of T12 to L1, and it bifurcates immediately into the common hepatic, which goes into the liver, and the splenic artery. And the splenic artery, further supplies spleen, pancreas, stomach, and the lower part of the esophagus. If you look into the celiac artery imaging, and when you do the CT scan, it normally arises anteriorly between 12 and 1 o'clock. Just a minute, because it's coming in between. Now, if you look into the bifurcation, it is a very important bird in flight. You can see the way the bird flies. So you can see the celiac artery comes out and divides into two branches. One is the splenic artery and one is the common hepatic artery. If we take this celiac artery on an angiogram intraoperatively on an LAO, so when you want to see the origin of the celiac artery or an SMA, we must do an LAO RAO. LAO means left lateral oblique, and RA, RA oblique. And at an 90 degrees, you will be able to see the origin of the celiac artery very well. Now, when you do the 3D reconstruction, so this is the first branch, the blue arrow, which you can see. So this is the celiac artery. Coming to the second branch of abdominal aorta, superior mesenteric artery. It arises nearly 1 centimeter below the celiac trunk at the level of L1 and L2 vertebral level. In less than 1% cases, it arises directly from the celiac artery. And left renal vein, it crosses right behind the first centimeters of the SMA. Now, superior mesenteric artery and branches provide blood supply to the pancreas, entire small bowel, and half or more of the large bowel, the colon, what we call it as. Now, the superior mesenteric artery also joins the inferior mesenteric artery by a branch called as marginal artery of the colon, what we call the Drummond artery. If you do the CT imaging, SMA imaging, it normally arises anteriorly between 12 to 1 o'clock, as you can see on the CT scan how it will look like. And when you take the imaging on the lateral, and you can see a very beautiful SMA, second number marked as yellow. And on the 3D reconstruction, you should see that branch where the blue mark is there. Coming to the third branch, which is the renal arteries, they start from L1 to L2 vertebral levels. It supplies blood to the kidneys, and they lie in retroperitoneal space. And when you do the axial CT imaging, this is how it looks like. As you can see, both the arteries may appear on the same axial slice, and sometimes the levels are up and down. The right renal artery is up and the left renal artery is lower. So then you can see the arteries in a different axial skin. Normally, you can see on an angiogram on the AP mode, like the renal arteries, you can see like this. But when you have to see the exact origin of the renal artery, sometimes you have to take the caudal view. Now, there is a variation in the renal arteries. Over 70% of the patients have two single renal arteries bilaterally. Up to 30% of the normal population can have an accessory renal arteries, and less than 0.1% have ectopic kidneys, like a horseshoe kidneys or a pelvic kidney, which is there. Now, contrast, we have to be very careful because some patients with abdominal aortic aneurysm had dearranged renal functions, and we can use a CO2 angiography in that cases. The fourth branch is an inferior mesenteric artery, which arises around 2 centimeters from aortic bifurcation at the level of L3 vertebral level. Now, inferior mesenteric artery actually supplies the blood to the distal third of the transverse colon, descending and sigmoid and the rectum. And if we occlude the IMA, normally the circulation from the SMA covers the rest of the bowel. Inferior mesenteric artery is much smaller in diameter. So normally, if you look into the abdominal aortic aneurysms, is chronically occluded in more than 50% of the patients. Coming to the lumbar arteries, so there are 4 pairs. They arise from L1 to L4, and they contribute to spinal cord blood supply. And it's a very important source of collateral flow to the pelvis by the hypogastric artery. And this is also one of the most common cause of type 2 endoleak once we put in the stent. How does it look like on CT scan? So this is how. Can you see the small arrow, the streak of blood just in the posterior laterally? So both sides you can see the lumbar artery coming out of the aorta. And on an angiogram, you can see beautifully 3 pairs of lumbar arteries here. And then you should also look into the aortic bifurcation. So on the CT scan, the aortic bifurcation should be minimum of 19 to 20 millimeter before we can put in the stent, bifurcated stent. If the bifurcation is less than this, then we must use aortic uni-iliac device. You should also look for calcification. Coming to the common iliac artery, it starts at aortic bifurcation, and it's very tortuous sometimes. It divides into external iliac artery and the internal iliac artery. And most of the time, the distal landing zone is into the common iliac artery. Important to know, in 20% of the patients, this could be aneurysmal. So if it is aneurysmal, then we have to land our stents into the external iliac artery. So this is how it looks like. It goes posteriorly and inferiorly on CT scan, and the left side, which is there, it goes laterally. Coming to the internal iliac artery, it's an important blood supply to the pelvis and the buttock. Accentive collaterals are present. The aneurysms of this part are rare and only 0.3 to 0.4%. And unilateral occlusion, if it is there, only 25 to 40% of the patient will get claudication. And it defines distal extent of the iliac limbs during EVAR in some of the patients. So this is how it looks like. As you can see, and very clearly an internal iliac. Sometimes if you want to see very clearly the origin of the internal iliac, then always try to do an opposite oblique and then see the vessel. That really gives you a very good view. External iliac artery could be a landing zone in some patients, and it could be tortuous. And this also is the source of morbidity because sometimes it's very small and taking the conduit up is difficult. And you can see the external iliac arteries here are very tortuous in some patients. Common femoral artery, as soon as the external iliac crosses the inguinal ligament, it becomes common femoral, and it's a very important part from where we enter. We should look for calcification and the thrombus, and this artery divides into superficial femoral and the deep femoral artery. Coming to the preoperative planning, we must, when we do the planning for the aortic aneurysm, we must see that the size of the aneurysm is at least 5.5 because less than that, the risk of intervention is more than the risk of rupture. We must do a CT angiography. We should not do an aortic aneurysm stenting on the basis of DSA. These are the main parts of the anatomy. What we call suprarenal aorta is above the renal arteries. Proximal fixation zone, where the stent is going to be fixed. Infrarenal sealing zones, body of aneurysms, distal aortas, common iliac arteries, and access vessels. So all these 7 points has to be taken into consideration when we do and stenting. So what I'm going to do is that we are going to do one by one. So the first of all, we should look into a suprarenal aorta. What is the things to look into? Suprarenal aorta is an angulation and a tortuosity. Because if it is very angulated, then the knob of the limb will be there and you will not be able to get the dilated tip outside. Then, it may have a very good problem in retrieval of the top cap. Then look into this angulation. So, once you see such an aneurysm here, that there could be a problem in the top cap retrieval. So sometimes what we do, we keep an extra stiff wire into the aorta. Look into another angulation, hugely angulated aorta at the top. Then proximal fixation zone, where the uncovered part of the stents will come, that is above the renal arteries. We must look up that there is not much thrombus or calcification, because then the fixation will not be very good. Infrarenal sealing zone is also very important, because here we must look into the calcification and thrombus, because if there is a huge amount of thrombus and calcification, then the fixation of the stent will not be very good. Then also look into the length and the shape. Now, the length of the infrarenal means the distance from the lowest renal artery to the start of the aneurysm. We must have at least 1 to 1.5 centimeter of the landing zone, what we call, because otherwise the seal will not be very good. Also look at, does it flare or taper? Because depending upon that, you can increase, you can see how good the fixation will be there. Now, neck angulations are very important. If the neck is angulated too much, more than 60 degrees, then we should use the devices which has got a suprarenal fixations. So wall contact, 60 degrees angulation is very, very important part in the top end. Look into this. So very big angulation. So that's why suprarenal fixation Cook device has been used in this patient. Body of the aneurysm, we must look into the maximum diameter of the aneurysm, how big the aneurysm is. Then you should look at the patent part of the lumen which is there, and the thrombus which is present, and what are the patent arteries like an IMA or the lumbar arteries. Look into this, a big aneurysm, but a circumferential thrombus, a huge amount of circumferential thrombus with a blocked lumbar arteries in this patient. Then you look into the distal aorta. Now, minimum diameter, what we require is around 18 to 19 millimeter, because the device's diameter, what we have is around 12. And if you look into two devices, two limbs which are going to go through that, will be somewhere around 22 to 24. So that's why we must have at least this diameter distal aorta should be there. Then also you should look into the orientation of the common iliacs and think about how the graft will sit down. Also look into the calcification, how big the calcification is. This is how the aortic bifurcation looks like. Look into this. Now look into this. Where is the aorta landed? I'll just put in the picture here again. Now, should you go from the right side or should you go from the left side? Now, let's say if you take the main body through the right side, the distal part of the opposite limb will land up into the aneurysm like this. And let's say, if you put this device in the opposite way, then the distal part would have landed up into the lower part of the aorta. I'm sorry, this slight technical error, but we should be able to get that. Let's look into the common iliac arteries. Then we should look into the diameters of the arteries, calcification, tortuosity, and also the suitable landing zones. Because the common iliac arteries could be aneurysmal, so then you need to decide exactly where you're going to land. Look into the aneurysm of the common iliac artery. It is like 37 millimeter common iliac artery. Could be a very small artery, external iliac arteries. So external iliac arteries, in this case, the right one is 6 millimeter, the left one is 5.5 millimeter, and also calcified. So this could really cause us a problem when we are going to take the device, especially on the left side. Then in this case, one should try that the device, the main body, we should try to take it from the right side if the artery is very small. Look into the tortuosity. So in this case, I will try that take the body from the right side, because the left side is much more tortuous as compared to the right side. This is how the measurement chart is there. We note down all the diameters and the lengths and decide about the length of the stent and the sizings. When we select the graft, let's say the body diameter over there is 28, then we need to oversize it by around 20%. So we will add approximately 4 to 5 millimeter to it. So the device which we should use in this case should be around 34 millimeter size device on the top. The diameter of the device should be around 34 millimeter. When we look into the body lengths, then we measure different lengths. One is from the renal arteries up to the aortic bifurcation, and then from aortic bifurcation, the internal iliacs and both sides, and then decide about what will be the length of the devices what we are going to use. We also can use a pigtail marker during the operation in this case, and then exactly decide what is the size of the body which we are going to use. When we use the iliacs, then we oversize them again by around 1 to 2 millimeters to 3 to 5 millimeters if the vessel diameters are bigger. And if the vessel diameter is very big, 18 to 20 millimeter, then we can oversize up to 6 millimeter more. Then we should also try to overlap the components. At least two flows should be oversized so that there is no type 3 or endoleak which is there. This is the access size for the sheets. If you have outer diameter of the vessels, and then you measure what are the size of the seeds which will go through it. Now comes to the which side the main body should go. It also depends upon the personal preference, but it also depends on the device rotation and the course of the graft, where the landing zones are better in the main body, and also the access vessel calcification and the thrombus. So like in this case, if I place a device like this, I know the opposite side will come into the aneurysm. But if I take the device like that, so I know the opposite side will come at the level of aortic bifurcation. So I would prefer a shorter straight route in this case and try to take the device from the left side. Now, outside the desirable criteria, if you want to treat the aneurysms, yes, you can treat them like a severe angulation, bad short necks, but the chances of endoleaks will always increase. So always remember, proper preoperative planning actually prevents a poor performance. I'll present one case. There's a young boy who came a few years back with shock, cardiac arrest in the emergency, 19-year-old in 2007. Very interesting case. CT scan done showed a ruptured splenic artery aneurysm, rushed to the theaters, bleeding controlled, splenectomy done. As you can see here, patient stabilized and patient survived. Post-operatively, we investigated what is the cause of this aneurysm in this patient. Patient got multiple aneurysms. We sent it for the collagen vascular disease. We could not get anything. We sent the artery for histology, couldn't get anything. We sent some blood cultures and an artery for culture also, and we could not get aneurysms. But when we did the CT scan for the whole body, patient had multiple aneurysms, common carotids, thoracic aorta, celiac artery, SMAs, iliac artery aneurysms. You can see renal artery aneurysms. So 13 aneurysms patient had, and they were all very big and they were all saccular. So we thought we will start with one by one. Subclavian artery aneurysm was very big, and ventricular aneurysms was also there in the heart. And we thought, okay, so this patient has financial issues also, so we had to take approval from the government, and we thought, let's start with one by one, whichever is the biggest aneurysm, we'll start with that. So we thought we'll repair the right iliac artery aneurysm, which was very big, as you can see here. And we did an open repair of this aneurysm. As you can see, we made a cut, we put in a PTFE graft, and the patient did very well. Then later on, we thought we do a celiac artery aneurysm, and then we did an endovascular route because it was a very major surgery. And we placed the stent into that, and we saved the SMA, and still there was a small endoleak which was left. We left that, and when we took a check CT scan after 3 weeks, this small endoleak in the celiac artery area aneurysm was sealed up. Then we also gave these patients 2 months of antibiotics, and we found that 3 months CT scan, the aneurysms in the carotid and the thoracic aorta were getting smaller, and they actually subsequently disappeared. And that's why the ventricular aneurysm, which was there in the heart, which was very small, which didn't treat it. Then patient had a pain in the right loin. So we thought, okay, now we need to treat the right renal artery aneurysm. We went through the brachial route, placed a wire, we placed a covered stent in the right renal artery, and the right renal artery was sorted out. Then when we took a check angio in this, there was no leak, and patient was discharged, and we thought we will repair after 2 weeks the right subclavian artery aneurysm. But patient came back in an emergency with a rupture of the right subclavian aneurysm, and then we had to take the patient for thoracotomy, and we did an open repair of the subclavian artery aneurysm in September 2007, as you can see, with a trapdoor incision, and he survived. So he survived this surgery also, and he did very well. Then we did well for 1 year, and we found that he developed another aneurysm at the lower end of the PTFE graft, which we have repaired the right iliac artery aneurysm. So you can see a small pulsatile mass there, and then it was about to rupture. We took the patient for extension of the PTFE graft in the right iliac, and at that point, the endovascular repair was, the graft prices was slightly an issue in this patient at that point. So we did an open repair, and we survived. And then we took an angiogram after 1 year, and we found, as you can see, no aneurysms in the aorta, carotids, subclavian has sealed up, celiac artery was doing well, right iliac aneurysms were healed up, renal artery was sorted. So we were very happy with this patient. But 3 months later, this patient came back with an abdominal pain, and what we saw, lower end of the celiac artery at the level of SMA, patient has got a big aneurysm there. You can see their leak over there. So we wanted to repair this. So what we did a hybrid. We opened the patient, we did a graft from the aorta to the right renal and an SMA, and then we did an extension of the stent graft. So this is ligation of the renal arteries and SMA with a graft, and you can see, and then we put in an extension of the stent into this patient, and this was a hybrid surgery. He did very well, and patient got discharged. 2 years later, he came with pseudoaneurysm because this patient had undergone dialysis. Now he has got a pseudoaneurysm of the AV fistula. So we did a thrombin injection, ultrasound guided percutaneously. He survived that, and he was on continuous dialysis. Then he came in with an SAOIO, intestinal obstruction, for which an exploratory laparotomy was done, and he did very well after that. So this was in March 2015, and he did very well, 8 years post-operatively. I could not get the slides, but this patient came back 2 years later, in 2017 with an aneurysm from the lower end of the aortic stent. Now the infrarenal aorta was aneurysmal. So what we did, we reimplanted the inferior mesenteric artery into the left common iliac artery and then extended the stent into the aortic bifurcation. So another hybrid operation we did on this case, and very unfortunate, in 2019 he was come to that because of renal failure. So he survived 11 years with lots of aneurysms and complicated surgeries, and we were very happy with the technology what we had with us available, which could make this patient survive. Thank you.
Thank you, Dr. Rahul, for taking the session in such a lucid manner. So now the session is open for Q&A. There are some questions posted in the chat box, sir.
I will start the cases. And so the first question is, what to do in case of circumferential thrombus at the fixation zone? Now, you see, there are, one is, you know that this patient could have an endoleak. So if the circumferential thrombus is over there, we should always try to use the devices which has got a suprarenal fixation, like a Cook device and Medtronic device. So you have the hook at the top. Second is, you should take the precautions that you should not try to do the ballooning at the top end, because the clots can go into the renal artery. So you should be prepared that you can throw the thrombus into the renal artery. Third is, if you still have an endoleak after the device placement, then you may have to do either a chimney, or where you can extend the stent, or in the first go only, you can go directly into the fenestrated grafts. If the money is available and the expertise is available, then you can go directly into the fenestration. What that means is, you have fenestrations into the stent which are placed at the level of renal artery, and you can have the landing zone into the suprarenal aorta rather than into the infrarenal aorta. Second question is, if patient aneurysm size is less than this and has symptoms, pain extra, should patient be treated or kept on follow-up? Normally, patients less than 5.5 centimeters will not have pain, because the pain could be from some other reasons. But if still patient has some pain, then you should evaluate, is this patient pain coming from aneurysm? If you are in doubt and you could not find any other cause for pain, and if the patient has sacral aneurysm, then it's better to treat it. But normally, aneurysm less than 5 centimeter will not have a pain in abdomen because of aneurysms. Then how to manage type 2 endoleak? Normally, type 2 endoleak we manage conservatively, and we wait because most of these arteries get thrombus because they don't have an outflow. But if on the serial scan, aneurysm size is increasing, or the leak is increasing, or the leak is not settling down, then we can go directly into either into the sac, CT guided puncture of the needle into the aneurysm sac and put in a glue or a thrombin. Or we can also go, if it's from the IMA. So we have done one case where we went retrogradely through the SMA and throughout the whole artery of Drummond and blocked the artery from a region into the IMA. What if the patient have calcium in the neck of the aneurysm? Whether patient should be treated with endovascular option or surgery. You see, endovascular option or surgery depends upon not only the calcium, it also depends on the age of the patient. So if the patient is fit for an open surgery, it's better to go for an open surgery. But if the patient is not fit for an open surgery, then it's better to go for an endovascular option. It also depends upon what is the local expertise available. You see, we don't treat too many aneurysm patients. So the people who are trained in doing an open surgeries are very limited. And the people who are going to treat an endovascular treatment options are also very limited. So it's not only the calcium which decides. You could have a very, very, ring of calcium at the neck level, which you can still treat an endovascular options by extending the, as I told you, using a fenestrated options which are available. But yes, open surgery will remain an option, because if it's a very calcified neck, then open surgery will also be very difficult. How you rate the success rate of EVAR as compared to open surgery? The success rate of EVAR will always be lower than the open surgery if you look into the follow-up of the patient, because EVAR patients will always require some re-intervention. But you need to compare. We cannot compare, apple to oranges. 45 years, 50 years old male with an aneurysm, we should always do an open surgery unless patient has got a poor cardiac reserve. So let's say 50 years old guy with a massive COPD, ejection fraction 35% of previous MI, then he may better off with EVA rather than an open surgery, because the mortality with open surgery in that case would be very high. So you need to look into a lot of things before you decide between open and EVA. And it all depends upon the mortality perioperatively and compared to a re-intervention rate in the follow-up years. Because if your mortality perioperatively is very high, then the patient is going to die during that period, then I will prefer to do an EVAR, and these patients may have 5 to 10% re-intervention rate later on. We can treat that, re-interventions. But, it all depends upon the size of the aneurysm, the rupture risk, the risk of surgery in that patient, and the risk of intervention. Anatomy of the aneurysm, if the anatomy is very bad, then the risk of intervention will be more. So it's a slightly complicated decision to make. It's not very straightforward in one line. You can say you should do open, you should do EVA. Okay, there are no more questions in the chat box.
Sir, should we wait for 2 more minutes?
Yeah.
Thanks. I think there is no more questions, sir. So it is always a sheer pleasure, sir, sharing your expert views. So thanks once again for sharing your expertise and your views on endovascular management of aortic aneurysm. So thanks once again for sharing your valuable time, sir.
Oh, sure, welcome.
Participants also, sir.
Okay.
Right.
Thank you again for arranging it. Thank you. Bye-bye.
Right. Thanks, everyone.
Bye.
Thanks. So we can disconnect now.
Yeah.
Thanks.